So yeah, just to give a bit of an introduction. So we've been asked to come and talk about how we do the allocation, the resource allocations to ICBs, and also to provide a little bit some information, a bit of a demo on our place-based tool that we've developed, which allows people to look at the sort of the needs the needs at a sub ICB population. So in terms of our team, so we're the Analysis and Insight for Finance team. We are in the process of moving from strategic finance into data analytics in the transformation directorate as part of the new NHS programme. But we're still, we've always had sort of working relationships with both sides in terms of got really close working relationships within strategic finance in terms of delivering the resource allocations, but also those links into analytics as well. So just to give a brief overview of what we're going to talk about. So I'm going to talk about how ICBs are calculated. To say I'm Heather Ross. I'm the senior analytical lead for allocations within the Analysis and Insight for Finance team. So I'll give a brief overview of how we actually calculate the ICBs. Then Daniel Sutcliffe in my team is going to give a bit more of a detailed dive into how we develop particular models that sit within the suite of allocation models, and he'll use the development of the General Acute formula to do that as an example. And then Elbreth is going to introduce and give a demo of the place-based tool. So in terms of an overview of allocations, so within the allocations, we have to focus on how we distribute the available funding that we have to ICBs on a fair basis. So there's a fixed pot of money. So how do we share that out fairly, given that different populations have different levels of need for healthcare? So this slide just gives an overview of the allocations process, and there's 4 main steps within this. So the first is where the majority of the work of my team sits, which is around calculating the target share for each ICB. So this is based on the allocations models that we produce, sort of looking at the different health needs of different populations. And so this works out that, you know, dependent on the needs of the population of an ICB, what is their fair share, what is their target share of any funding that's available. So we're not trying to model how much money is needed, because that is never going to be the amount of money that's available. So it's about how do we share out fairly the amount of money that we have to be able to distribute. Then the next step is to calculate the target allocation. So this is just derived from the target share that we've calculated through our allocations model, applied to the overall sort of quantum, the budget, the overall budget that there is. So that's the target allocation for each ICB. This is then compared to the baseline funding for the ICB. So this is the current amount of funding that an ICB is getting, which might be different to what their sort of target fair share should be. And from this we get what we call a distance from target. We then apply something called a convergence policy, and this determines how quickly ICBs move from their baseline current funding towards their target share of funding. We can't move everyone straight away, because you can't suddenly take a lot of money out of a system, because you'll destabilise that health economy. And also, if you suddenly give an ICB loads more money, they're not necessarily going to spend it in the most effective way. But the aim of the convergence policy is to move everyone towards their target over time. So after the convergence has been applied, this gets you to the final allocation, so the amount of money that each ICB has. So the main focus of this presentation, so sort of my overview, and then Daniel's sort of deep dive into one of the models, is on that first step. So it's around how do we calculate that target share, but all of these steps are important in actually determining how much money an ICB gets at the end of the day. So the approach we have to take in setting allocation is actually outlined in the mandate from the DHSC. So, and it's based on the principle of ensuring equal access to equal needs. That has to be at the heart of the way we allocate budgets. But it also has to be informed by NHS England's duty to have regard to reduce inequalities between patients with respect to their ability to access services and to the outcomes that they're achieved. So these two aims of equal access to equal needs and reducing health inequalities are reflected in how we develop the target formula and that sort of fair share, which is based on kind of a complex assessment of factors such as demography, morbidity, deprivation. So the target share is actually determined using a sort of this complex set of weighted capitation models that estimate the need for populations with different characteristics. And in general, it leads to more resources being directed towards areas with higher health needs, whether that's because they've got a larger population, they've got more older people, a population with worse health or a more deprived population, but also to areas with higher health inequalities or higher unavoidable costs of delivering healthcare. And the allocations model has been developed over a long period of time. And it's kind of a suite of different models for different services. And we're continually sort of updating them, developing them, using new data sets, for example, so that we're always allocating resources on our best estimate of need at that point in time. And the development of the models is overseen by an independent committee called ACRA, which is the Advisory Committee on Resource Allocation. And this is made up of sort of NHS managers, GPs, public health professionals and academics, health economists. There's also sort of representation from the BMA and from local authority association. And so we sort of do the analysis, we present it to ACRA, and then ACRA make the recommendation on any changes to the allocations model to the leadership of NHS England. So it's just making it gives us that sort of distance and that kind of overarching sort of like independent committee that makes the decision on any changes that are actually made, which will impact on the amount of money or in terms of the how the money is distributed. So as I've said, the allocations are based on a series of statistical models that identify factors that can predict future spending on health services. So the starting point for the majority of our models is utilisation, sort of as measured by sort of cost of healthcare that's been delivered for particular services for the registered population. So we'll take a cohort of the whole registered population. We'll for a financial year, we will identify the cost of providing healthcare for a particular service, whatever we're modelling at that point, over that period of time, and link it into that cohort. We then test a range of need and supply variables to identify which variables are statistically significant in predicting costs for individuals. So like I say, so we include need and supply variables. So we include supply variables when we're looking at what's predictive of cost. But when we're actually using the models to work out how to distribute resources, we sort of sterilise the supply variables and set them to the national average so that we are doing those predictions based on need and not based on access to services. And as I said, you'll hear about a particular example of how we developed a model in the next section from Daniel. And so we have, oh, sorry, I've gone ahead too quickly. So we have different models for different components of healthcare because need for different services is different for different populations. So you can see from the age cost curves in the bottom right hand side of this slide, how need varies differently by age and sex for different services, and therefore that's why we have different models to reflect that different populations are going to have different needs for different services. So you can see that particularly that the mental health age cost curve is very different to the others in that it's got a peak early on and then a later peak. And the community services age cost curve is ramps up really high, but at quite old age, compared to general acute, which starts to ramp up about 65 plus. So as I said, there's different components within the formula. So we have two main formulas, two main allocations. One is the ICB core services, and one is for primary medical care. There is also going to be one for specialised that we've been working on developing, sort of reflecting the sort of delegation of specialised services to ICBs and the need to start distributing the money for those on a needs basis. But within ICB core services, it's sort of further broken down into different components, each of which has their own model. So reflecting that the need for each component within that will vary between ICBs dependent on the makeup of their population and what the drivers of need are for that component. And the influence that each of those components has on the final model is driven by the proportion of sort of modelled expected expenditure for each of those components. And then that's sort of combined to create the overall ICB core services target allocation. But there's also other adjustments. So within core services, so just under 90% of the allocation is used as the needs-based model, with just over 10% being a health inequalities adjustment, which is currently based on a measure of avoidable mortality. But then there's other cost adjustments that are made within that total allocation. So the market forces factor, there's an adjustment in there for unavoidably small hospitals in remote areas, so hospitals that have to exist to serve a population, but they can't operate at an efficient scale, and therefore their costs are higher. There's also an adjustment for unavoidable sort of finance costs with it for PFI, and another adjustment, the emergency ambulance cost adjustment, which reflects that sort of longer travel times for ambulances in remote areas. So for the health inequalities adjustment, said in core services, it's about it redistributes 10% of the quantum of money, and in primary care it's 15%. So reflecting the expectation that you can have a bigger influence on health inequalities in primary care than in secondary care. Okay, so I think I'm going to hand over to Daniel now.
Are you okay to do this?
Yes, yeah.
Okay, perfect.
Yeah.
Hi everyone. So yeah, I'm going to talk a little bit about the general and acute model and the steps we took and the kind of things we need to consider when developing the general and acute model. They're also the kind of things we consider when we're looking at other models that Heather was just talking about. So for the general and acute model, I guess the first thing is that it's a linear cost model. It's a person level model. So what we're looking at is everybody who is registered at a GP practice in England at a certain date. So that's 59 million observations around. And the goal is to estimate an average cost per head in the population. So that's our goal. We want to know what the average cost by age and sex by GP practice ultimately in the population. But we model it at a person level. I want to talk a little bit about the motivation for a linear cost model approach. And one of the motivations is it's the simplicity in implementation and interpretation, and the tools we have to assess how well the model is doing, so how good a model it is. So as you probably all know, In linear regression, the coefficient retains the natural units of the dependent variable. So we interpret the coefficients as pounds and pence because that's what the dependent variable is. The dependent variable is the cost of healthcare that we're using in general and acute. And being able to interpret the coefficients in pounds and pence really helps to communicate how the model is working, the impact of important variables such as ethnicity, age, and sex on the dependent variable. As you also probably know, there are issues with the linear cost modeling in terms of potential problems around multicollinearity, susceptibility to overfitting, outliers, non-linearity of relationships. So these are all things that during the model process we will look into and make some decisions about. So for example, with age, we know there's probably going to be a non-linear effect with age. So we transform age using a tool called age splines as a method of looking at the relationship between age and the dependent variable. Outliers are less of an issue when you're dealing with 59 million observations, a few outliers at a aggregate level, but because ultimately the model, we want to get the average age by average cost by age, sex, and GP practice, those outliers can become an issue when we're doing predicting at lower level of localities such as GP practice. So those are things we need to kind of bear in mind with. So in terms of the dependent variable, we include costs associated with admitted patient care, outpatient, and accident and emergency attendances. We exclude maternity services and specialized services because they have separate models. And we use HRG prices where available. So these are pre-populated. So we use SUS+ data, and so where the HRG price has been used for payment, that then the costs are pre-populated with adjustments for length of stay and all those kind of things. Where costs are unavailable, so there is either a local price or it's not used, it's not part of the national tariff, then we will estimate costs using PLIX or in the past reference costs, but we will follow the same methodology that is used to create national prices. So there are certain set steps that the pricing team within NHS England follows in order to create prices. So when we're estimating costs where there isn't a cost already using PLIX, then we'll follow that same methodology. Sometimes there are indicative prices, which are not mandatory, but they're probably our best estimate of what the cost might be where there is actually missing cost. So having constructed our dependent variable, we then take the next steps to quality assure the dependent variable. So looking at age cost curves by clinical area, for example, looking at outlier detection, these very high costs, which as a aggregate model may not have a huge impact, but when we start predicting at lower level localities, that might have an issue. We also look at geographical mapping and local engagement. So people know, for example, in an area, whether their relative costs are higher for a particular reason. So is there a data issue in a particular area which might be explaining something? So I guess part of the quality assurance process of the dependent variable is kind of local engagement as well. Next slide. So we have two sets of explanatory variables. Having developed our dependent variable, we now need to develop our independent variables, and we tend to split them into two types, although there is a kind of overlap in some of these. So in terms of need variables, so drivers of need, we look at previous diagnostic history, we look at age and sex, ethnicity. We can also develop variables based on household types. So we're able to say, is this a multi-adult household? Is this an adult, one child household? So we can develop a household type variable. And then we have the number of attributable variables, such as variables based on your GP practice, deprivation measures, etc., QOF, for example. And then on the other side, we have supply variables. So your supply may be the CCG in the past when they existed, and I'll talk about those type of supply variables in particular. We might also have distance to your nearest hospital, and we may have variables related to hospital supply variables. So broadly speaking, these might be classified as kind of capacity. So the capacity of the hospitals in question. And we only use those variables that are actually predictive of use. And I'll talk shortly about how we go through reducing maybe 1,000+ variables to a more manageable model. Next slide. So I just want to talk a little bit about supply variables and the method we use to deal with them in the model. So supply variables are taking into account factors affecting costs that are not related to need. And the final specification of the model includes both need and supply side variables. However, we're aware of the impact of letting supply variables determine the cost prediction. Because if you were to just allow supply variables, because they're significant in the cost prediction, to remain in the model, it produces a kind of circularity whereby you're allocating more money to areas that have already invested in more supply of healthcare. And so the method we have is we call it sterilization, and it's a way of ensuring that the supply variables do not impact the setting of allocations. And the method we do is that once we've fitted a model, we then take our supply variables and set them to their mean. And then we run the prediction. And what that has the impact of is averaging out the effective supply across all observations. Next slide. So one of the big issues in all of this, and as you guys probably know, is around selection of variables and how to assess the model fit. So our method to variable selection is we have a number of different methods, but ultimately we use an iterative approach where we fit a model and increasing values of t. We remove variables, then we refit the model, and then we run the regression again, and then at higher levels of t, start removing variables. So it's a very iterative process, usually involving maybe 24 or so iterations. 24 regression models need to be run, dropping variables at each step. But in addition to that kind of very statistical approach, there's also a kind of clinical engagement to ensure that we're thinking through what the size of the coefficient is, what the direction of the coefficient is, getting clinical advice about what the most appropriate variables would be and how and what's the best way to formulate those variables and to test them within the model. As I mentioned before, we have a data set of 59 million observations, which allows us to partition the data. We actually partition the data into 3. So a training, a validation, and a second validation. Because as I mentioned earlier on, ultimately, we'll use the data at GP practice level, so age sets in GP practice level. So we want to know what's the fit at a person level. So, and that will be our training model. We'll then see what does it look like on the validation data set. And then we'll see what does it look like in terms of model fit at GP practice level. Because obviously the R-squared for person level models tend to be quite low, but at higher levels of aggregation, you get higher levels of fit. There is no one measure of model fit. So on the screen there are just a handful of the measures that we might use to assess model fit. There are others. So, for example, for nested models, we might look at the change in deviance, for example. And I guess the main message there is that we wouldn't just use one measure. Sometimes these measures can actually be in conflict with each other. So, for example, when you're comparing models, you can have one model which has a higher R-squared, but actually has a higher mean absolute error compared to other models. So there's a lot of discussion about what actually a model makes more sense in terms of face validity, and if there are other tests we can do, and what other discussions beyond the purely statistical in terms of what might make the best model. So the quality assurance is actually obviously quite important, vital for all the work that we do. And I mean we as in like analysts generally, I guess. So some of these steps are there listed. So we review the coding within the software package that we use. People check, so on the SQL side, people will check the SQL, and then when it comes to the statistical packages that we use, someone will also check through and provide support for the coding. We look at the results of plausibility. So, for example, the size of the coefficient, the direction of the coefficient, does actually make sense from a face validity perspective, and also outliers are investigated. As I just mentioned, we look at the direction of variables, and sometimes they are unexpectedly negative. So, for example, ethnicity, when we look at mixed ethnic groups, what the models seem to be suggesting is that there was lower need for healthcare or general and acute healthcare for people with mixed ethnic groups. And there was this very definite trend that this was happening. I guess our governance group that we present all our findings to discuss this in depth. And what their view was, actually, this is not a reflection of reality. What it's more likely to showing unmet need. And so rather than build in what we think would be unmet need into the model and therefore into the allocations, we set the coefficients for those variables to 0. So what that means is that the effect of ethnicity is never to reduce allocations. It's either to keep it to the same level as the base category, which is white British, or to increase. And obviously that would be part of our clinical engagement and local engagement. And all results from modelling and outputs are presented to our governance groups, which is TAG and ACRA. Next slide. So this is some of the results from the GNA model, and it's looking at age quintile by deprivation quintile. And you can see that the results are, I guess, as you might expect, you know, so you're seeing that the least deprived and youngest age groups have the lowest need indices. And as we go through to the older groups and more deprived groups, we can see that there's a general trend towards higher need indices. And so the results are, I guess, from a face validity perspective, I kind of guess what you might expect. Next slide. And again, what we're also able to do, and this is part of our engagement work as well, is looking at the geographical spread. So these are local authorities, and we've got the need indices by local authorities, and we can see that the GNA, there's this trend where more challenged communities have greater need indices. So again, kind of what you might expect, and this is part of our engagement process to kind of show the kind of geographical variation and the impact the model has in relation to what we'd expect to need to be in the community. And I think that's it from me.
Yes, I think I will be taking over. Are you okay to still do the slides? Perfect. So my name is Elbert Putz, and I'm a senior analytical manager in allocations in the analysis and insight for finance team. I work on health inequalities and the place-based tool, which I will be telling you about a bit over the next slides. I'll start off with some context first. So while our models use individual and local area level data, they determine the share of resources to ICBs only. When that then gets to the ICB, it's up to the ICB to decide how they want to allocate their resources to the places in their system. So we developed this place-based tool I'll show you in a moment as a reaction to the reorganization of up to, at some point, over 100 CCGs to just 42 ICBs, meaning that the bodies that are responsible for commissioning and making decisions about place-based allocation now are responsible for often much larger areas that often are also quite diverse. So the aim of the tool is to support ICBs in understanding that diversity in need in the smaller areas within their system. And it does this by providing information on estimated relative need rather than giving figures in pounds. So if you recall some of the figures that Heather showed earlier in her slides, the ones I've sort of pasted on this slide here, could you click next for the, yeah, great, how that works. So this is sort of what is in scope of the tool. It's just the target shares, and also it doesn't include the cost adjustments separately, although they would be included in the final sort of core services need index. Next slide, please. So historically, the data that the tool actually uses, we have always published in spreadsheets as annexes to our technical guide, and we still do this, but the tool is more of a sort of user-friendly and guided way to create bespoke and more meaningful sub-ICB places that go all the way down to the GP practice level. An important difference between those spreadsheets and the tool is that the spreadsheets provide need indices relative to national need for individual GP practices as well as for the aggregate ICB level, whereas the tool provides weighted populations for those bespoke created places and then calculates need indices that are relative to the ICB. And the aim of providing that information is that those insights might be able to help inform discussions or even a method for allocating to place at the ICB level. So the key insights from the tool are those need indices, which show need relative to the ICB as a whole. And so the need of the ICB as a whole would be 1. And if you have a need index of less than 1, that represents sort of less need compared to the ICB for that place. And above 1 would represent more need relative to the ICB. So what this tool does is it allows you to download those results as well as save your session. And then now I'm going to steal, I think, the share screen. Just bear with me, because I will show you the actual tool. Here you go. So I'll just give you a quick walkthrough, just to note that the code and data of this tool is all open source and it's hosted by GitHub, on GitHub. And when we use this app Streamlit to run it and essentially give it a front end. And when I say we, I have to give credit to our colleagues who've done this. It wasn't me. So when you are here on the front page, basically the left-hand side here is expecting some input, and the right-hand side here is presenting the results. So to use it, first you would select a time period that's covered by this tool. This tool covers 2 time periods, 23, 24, 24, 25. I think for the demo it doesn't really matter, but just to be aware of. And then you select the ICB that you're interested in. And I've had a peek of some area that's covered by you guys. And I've decided on Derby and Derbyshire. And what I'll do is I'll create 2 places here so that we can also compare them. So once you've selected the ICB, you can select a local authority here to basically help you filter the large number of GP practices that are in this ICB, but you don't actually have to. Like, you could just individually select them here. But I am going to use local authority because it's just a bit quicker. And I'll first select Derby. And then I'm going to say select all the GP practices in Derby. Sorry, I'm on my touchpad, so it's not ideal. I'm going to give it a name, Derby, surprisingly. And then I'm going to do the same for the Dales, I've decided. So I'll select all. There we go. So the panel on the right here now first shows you where those practices that you put in your place that you've created, where they are sort of geographically. And it also prints here below that which ones are actually included. And when you scroll down, which we will do in a moment, you'll be able to see the need index for, or the need indices for these for this place, consisting of these GP practices. First, you would need to like select which ones you want to inspect. So let's inspect Derby first. Sorry, this is always a bit of a pain. Right. So now these are the sort of need indices for this place, for Derby, local authority. And basically what this shows, if you remember that 1 would be the sort of overall need of the ICB, is that this place has lower general and acute, lower community, lower prescribing need, and slightly lower primary medical care, but it has higher mental health, maternity, and health inequalities. If we then go back and we compare this with the Dales, the Derbyshire Dales, we see kind of the opposite. So there's a higher need for general and acute community prescribing, and lower for mental health, maternity, and health inequalities. This is not an unsurprising sort of pattern to see when you're comparing like a rural area, which would be the Dales, which has like a more, in general, more affluent, older population compared to an urban city that has a younger, more deprived population. So if you scroll down here, you can also preview the download for your places. So this also gives the weighted populations and the need indices. If I scroll to the right, which, well, I'll do that here, so you can see them together. It also gives the national information, I should add, on the ICB as a whole. And you can download this information by clicking here and downloading a zip, which includes a CSV with these results, a README file, and also a JSON. And this JSON can be uploaded later if you return under advanced options. And you can just drag and drop it here or browse files, and you would basically return to this, this window. I wanted to add that the coding in the JSON file is really simple. So I don't know. So all of this is written in Python, and I don't actually know Python, but it's just basic coding. And if it's easier for you to manipulate like what places you want to create in that way, I would definitely give that a go. It might be easier if you, for example, need a lot more smaller sub-ICB places, such as PCNs, if you know the practice codes and the names for these PCNs. And all the practice codes and names are available from our spreadsheets. Heather, I'm going to close this now, and then can we go back to the presentation for one last slide before I close? Stop sharing. So yeah, that was basically the tool. We have got a couple of other tools that Heather is going to bring up. I see it, but you don't see it yet. Okay. So we also have a waterfall tool, which is basically a dashboard in Excel with waterfall graphs. And what that tool does is provide insight into the drivers of change from allocation to allocation for specific ICBs. And such drivers could be, for example, financial policy adjustments, baseline adjustments, or demographic factors. And then this is an older version, that's fine. Our technical guides and the annexes, as I mentioned. So the technical guide gives a lot of detail on the tool, including kind of what Daniel covered, but for all the segments of our model. And the annexes contain weighted populations and need indices. So basically what we use at ICB level and GP practice. And finally, our most recent publication is an infographic slide pack, which explains our model, the approach that we use, using helpful metaphors basically to make the technical guidance essentially more accessible. Could you go to the next slides? I'll close it here, but basically all those items are available via that link on this page. Realize it's 5 to 12. But yeah, if there's any questions, we'd be happy to try and answer them. And if you have any thoughts about, for example, the tool, which is very much like in development, we'd also be very keen to hear it. And thanks for inviting us to talk about these.
Thank you very much, all three of you, for sharing that with us. That's been very insightful. There are bits of it that I kind of remember from having been involved with this process before, not at national level. So thanks very much. That was really interesting. We do have a few questions from our lovely audience, and we won't have time to go through all of them. So I'm going to pick on one or two of them and see if you'd like to sort of respond to them. So I wonder if so Peter, if you're still here, you put a question in the chat box. So if you'd like to just read that out, that would be really helpful.
Is that my job to read that? Thank you, colleagues, for that. I've got lots of questions, but there's no time to do it. But maybe on another time, I'd be interested for you to run through what the predominant critique is of the way you do it, and just because there's no right way to do these things. But I was just interested, it may be that your waterfall thing that you mentioned at the end would answer this for me, but if you kind of start from, if we took the budget and just divvied it up per head, we know that's not quite right. So let's introduce adjustment for age, then let's introduce adjustment for need, then let's introduce, and then down the track we do all these things around market forces and so on. A long time ago, when I last looked at that, I was surprised by how significant some of those latter stage adjustments were. And I had a slightly sneaking feeling that we were, at the very last bit of it, we were suddenly skewing the money into richer places on the grounds that it was more expensive to live there and employ people there. And that felt uncomfortable for me. And when I looked at the kind of the way it cashed out, it sometimes seemed to cash out at almost doubling the level of resource per head. And I just wondered if you, in amongst the stuff you've produced, is there something that would illustrate that movement?
So I mean, the waterfall tool that you mentioned is more about between allocation rounds what's changed and what's changed for you. In terms of other sensitivity analysis, we have done some bits of that. But yeah, I mean, I'm always quite surprised at the extent of the impact of the MFF. But because we strip out the MFF when we're doing the modelling, we have to add it back in because it reflects what the commissioners actually have to pay for the services for the providers that they're using. Yeah, it does have quite a big impact. Yeah, some of the other adjustments are a lot smaller, but the MFF is the cost adjustment that has the biggest impact. But because it's reflected in the prices that they have to pay for the providers, then
it's all internally consistent, but the end result is we put vastly more money into richer parts of the country. But I think it would be just as a suggestion really to help people, if you did have time at some point to produce something that kind of showed the impact of each of those stages of adjustment, because it makes the point about just how significant it is. And this is the single most important decision NHS England makes, isn't it, really? And the more we can unpack that and illustrate it, and help people understand the significance of each stage of it,
and within all our technical guidance that's published on the website, we do split everything out so that you can see, for example, the need index for everything that we put in there, and within that there's an MFF index in there, for example, so you can see the impact that it has at an ICB level. So so we do publish each of the different components, and how need varies at GP practice and ICB level for those, and then there's also a worksheet which kind of brings it all together, which sort of helps you see what the impact is at each stage. But within a model, we don't have that broken down, if you see what I mean. We have it broken down within the different components of core services.
If you're doing your infographics and things, just anything that can help people, it's just like the starting thing. We make all these adjustments and they have a really big effect. So we do need to debate whether they're right routinely, I suppose, would be anyway. But thank you so much for the session. Thank you.
Yeah, thanks. We are at times. Thanks very much. It does feel like we should come back to this. It feels like we might be inviting you again.
Yeah, and if people do have specific questions, then there's our email address that you can send them to, and we'll.
So people have raised. There are several questions, so we haven't got time to go through them now. So I won't share my screens because you'll be I don't know which one to address. I will share them with you. And I will, if you could be so kind as to respond to them, and I will share those responses with the analyst network. But it does feel like it's an area that people are very interested in, and it is very, very important. And so if we can help you develop that tool and sort of and the models and understand them better and share them more widely, then I think that's something we'll help to do. So thank you very much again for coming and for spending your time with us, and it's been very insightful, and hopefully we'll see you again. Okay, and see everybody else in a couple of weeks. See you. Bye-bye.
Thank you.
Bye.
Really interesting.